I think it depends on the tools and the specific formats that the AI is delivered in care. So, for example, if a test requires patient approval to be conducted, often because payers will not pay for that, or there is a heavy copay, then the clinical team, the clinician, will ask the patient whether they want this test performed. And that's a common situation. If the AI is embedded in some fully automated or hidden away way, for example, as part of the provider order entry system in the medical record, or as an ancillary or supportive assistive decision support tool for the clinician, the patient never sees that. Similarly, if the AI exists in the research pipeline of developing the standard of care, the patient will not see that. And that may also be invisible to the clinician herself or himself in many cases. The critical thing, I believe, is whether there is any risk from the AI, and therefore the patient has to consent to any such risk, assuming it has not been covered by regulatory approvals or other appropriate risk management steps. We don't see this happening yet in real life. And I think that in a well-managed system that enforces safety and regulatory review and approval of treatments, diagnostics, and every other major decision taking place in the process of caring for patients, that essentially this is not necessary at all, and nor is it ethically mandated, in the same way that nobody is telling the patient that their creatinine levels or their hematocrit levels, etc., were obtained by a particular biochemical protocol, reaction, reagent, or device, because once it's approved and certified and regulated for effectiveness and safety, there's no need, and it would make it impossible to actually care for patients if we bombard them with thousands and millions of disclosures about all the pieces of technology that are employed to make the care possible. There are way too many of those. It would not be possible to disclose all of them. It would also not have any real value for the patients.